And there you go, ventricular pacing. And this way we ensure that once we've done the ablation that we have not affected normal conduction in the heart, we've just gotten rid of the problem. And as we interrogate, we measure to see how the conducting system is dealing with the electrical impulses we are putting in to ensure it's behaving normally. And for electrophysiologists or trainees reviewing this, you can see that with ventricular pacing from the RV apex, conduction is concentric and decremental. Therefore, conductor of the AV node. You just saw a step out there with conduction up with a retrograde against the last one. A non-capture there of the ventricle, so ventricular ERP was reached. So all in all, a very good result, and the chance of cure of this patient would be 98-99%, and she's 21 years of age, and she would never need antiarrhythmic drugs for the rest of her life, and she will remain asymptomatic from an arrhythmia point of view. Just to review the catheter placement on fluoroscopy, and this was done without complex mapping, just fluoroscopic navigation. And done under conscious sedation, and she will leave a little later today. And this is incremental pacing from the A, looking at the Wenckebach rate, and also more aggressive pacing, basically to see if we get tachycardia induction. And there you go, that's Wenckebach, and tachycardia is not inducible. Generally, we wait about 20-30 minutes following these procedures to ensure that we haven't just bruised the slow pathway or raised a bit of swelling or edema, and that we truly have ablated it. However, an acceptable endpoint would be just a jump with one echo. That's just a note for physicians viewing this video. You don't have to ablate the slow pathway entirely, but a modification, and that's an acceptable endpoint. Sometimes trying to aim for perfection with a complete ablation may result in AV nodal block and a catastrophic outcome in terms of someone as young as this patient needing a pacemaker for the rest of her life. So we want to avoid that circumstance. And of course, if we get into tiger country with the slow pathway too close to the AV node, we could have used cryo, although it's not entirely, it doesn't entirely avoid the problem. You can do a test freeze to ensure no AV block before doing a full freeze. So there's a greater reversibility with cryo than there is with radiofrequency ablation. We don't use it as a first option in the adults, given that it's more effective and quicker. Cryo takes a little longer and a higher recurrence rate. However, in pediatric patients, cryo may be preferred. So this is an example of a simple and non-complex ablation.